Sir, we are live now.
Can we start?
Yes, please, sir.
So, good evening, everyone.
Good evening, everyone.
Good evening, sir.
My topic is, it's a vast topic, it's very difficult to cover in a single talk. So I try to manage it. As we know, hematogenous and exogenous osteomyelitis are very common. Before 2 years, the blood vessels crosses the physis. Infection easily travel to the joint. After 2 years, growth plate act as a barrier, so the chances of involvement of the joint become decreases. Third, they leads to premature physis closure and angular deformities and shortening. The exogenous osteomyelitis are very common.
Sir, sorry to interrupt. Sir, would you please share your screen, sir?
Share my screen.
Sir, we cannot share screen, sir.
The bottom, you'll have a green color button, which will have an arrow that will point up. You can click on that and share your screen, sir.
But I can't able to see it.
Sir, at the bottom of the
On right or left?
at the bottom of the screen, sir, there will be a green color button which will point up, sir. So you can just click on that and share your screen. You just did it earlier.
It's written, sir, share button, green button with an arrow, share button.
So I can't able to do that.
Sir, it is, if you can move your cursor to the bottom of the dialog box here, you will find that share option, sir. You can also click on Shift, Control and S if you're using Windows. Sir, you had just shared it when we were checking the PPT, right? So the same, sir.
Just a minute.
Yes, sir.
आपकी तो मीटिंग ही छूट गई।
So please go full screen.
Yes, sir. We can see your screen now. Thank you.
ILIZAROV in osteomyelitis, though it's a very vast subject to cover in this single talk, but this is the bread and butter for the reconstructive surgeons. Hematogenous and exogenous osteomyelitis is very common. Before 2 years, blood vessels crosses the physis. Infection easily travel to the joint and affects the joint. And after 2 years, growth plate act as a barrier and prevent the direct movement of the joint. But they leads to premature physis closure, angular deformities, and limb length discrepancies. Exogenous osteomyelitis are very common because of we are getting high velocity trauma due to composite loss of the soft tissue and bone. More and more, the use of the implant causes infection. This leads to severe scarring, deformities, shortening, and complex non-unions. So here the role of the reconstruction surgeon comes. If you see the basic principles of the ILIZAROV, it is a law of tension stresses. If you stress the tissues, they regenerate. The vascularity increases in a tremendous amount, and this increased vascularity, better delivery of the defense cells at the local site, better delivery of the antibiotic drugs to the local site, and it is able to control the infection. It gives you good stability. The stability against aid in the control of the infection and the healing of the fracture. And if you have any malalignment, you can correct the malalignment. It's a beautiful instrument. A few of the cases, tubercular fibrous ankylosing of the knee joint. We can see the gait of this patient, how she is walking. She wears bathroom slippers in both the hands and both the foot, and used to go in the field. And in this patient, we decompress the nerve, common peroneal nerve, and once the soft tissue stretch out, deformity corrected, and we fuse the knee joint in functional position. This is the picture of this patient after surgery. You can see the gait of this patient, how nicely she is managing. See another patient, crush injury, infection leading to the deformity, malalignment of the ankle joint. We do planning, malorientation of the ankle joint. We plan it, and we did a open wedge correction. You can see how it helps, the fixator helps you to correct the deformity. Nicely, the deformity has been corrected. The 6-year male following osteomyelitis, arthritis, scarring of the anterolateral ankle, and the patient is practically walking on the medial malleolus, on the medial border of the foot. And the whole of the foot, hind foot is shifted towards the lateral side. This is the X-ray of this patient. The ankle joint is completely lost. We again dissect the soft tissues and correct the deformity by dissecting the soft tissues. Once the deformity corrected, we fuse the ankle joint, and the limb length discrepancy will be later on dealt with. See another post-osteomyelitis, arrest of the physis, have severe angular deformity. We again decompress the common peroneal nerve, correct the soft tissue contracture, and once the soft tissue contracture corrected, then we do the intra-articular osteotomy and use a tricortical graft from the early crest and did the medial epiphysiodesis. This is after correction, and this patient needs limb lengthening. We will try to lengthen this limb. The female patient, again having the osteomyelitis, arthritis of the ankle joint, walking on the whole of the hind foot is separated towards the lateral side. We can see the calcaneus or hind foot has been shifted towards the lateral side. Patient is walking on the medial malleolus. We have the scarring. See the scarring of the lateral pars, anterior lateral aspect of the ankle joint and dorsum of the foot. We use the fixator to distract the contracted tissue, and we use the 20 gauge needle to have a multiple puncture on the scar tissue and gradually we distract it. Here we can see here there is distraction of the physis and the limb length has been corrected. So the scarring was so severe and adherent to the bone that the epiphysis opens. As we distracted, the epiphysis also opens and the limb length disturbancy has been corrected. It's a common scenario often we get after osteomyelitis in children. We plan it with a failed Huntington procedure, deformity with shortening. We use the ring fixator open ways correction, deformity corrected nicely. See another patient, neglected osteomyelitis, neglected for 10 years. The whole of the tibia has been lost. We transfer the vascularized fibula, translocate the vascularized fibula on the fixator in the defect. And how nicely the fibula has been incorporated and under load it becomes hypertrophic. See another patient, post-osteomyelitis, deformity and shortening. It's a very gross deformity, and during planning, I was not able to pass the use the fixator across the knee joint. It was very difficult for me. So I planned to correct the tibia distally. We did osteotomy at the synostosis side. We correct the deformity at the synostosis side and gradually lengthen it. And you can see the lengthening is progressive. And this is the, at that time, patient develops infection and the pain, so we have to prematurely take out the fixator. Now, after taking out the fixator, you can see the deformity has been corrected. And now the knee, we are planning to relocate the knee also. This is the, you can see the gait of this patient. This is pre-op gait. This is after surgery. See another neglected post-infection. A 35-year-old lady comes with this neglected loss of the tibia, post-infection loss of tibia, and how she is walking. We use the fixator to correct the fibular deformity and translocate the fibula in the defect. So how nicely incorporated. And you can see the gait of this patient. It's a pre-op and it's a post-op. See another patient, loss of tibia and anterior soft tissue, but the fibula was intact. So we treat him similarly, use the fixator and translocate the fibula in the defect. And the patient is with AFO, protected weight bearing, and as time passes, it will hypertrophy. See another neglected stiff mal non-union, osteomyelitis, scarring, treated so many years. We use the ring fixator and we distract them. As we distract them, the fibrous tissue becomes ossified, known as the transformation osteogenesis. Nicely healed fracture. It's a common sequelae of chronic osteomyelitis. We have the stiff non-union with the deformities. We use the open ways hinge correction. Fracture started uniting. Once we remove the fixator, the patient develops a fracture through the pin tract. So this is a common complication. To keep them protected by braces for say around for 2 months or so they will not get these sort of complications. So the normal shape of the bone is the only one suitable for normal functions. The 20-year-old male amputation on one side, infection on the other side, debridement, latissimus dorsi flap, and the plastic surgeon used one of the scapular border to fill up the defect. But here you can see the fixation is not good. It's an unstable fixation. So there's no consideration for the limb length. We give him stability, correct the foot deformity, and the fracture united nicely. So this patient needs only stability. If you give stability, correct the foot, everything will be fine. The post-osteomyelitis pathological fracture treated by passing a intramedullary nail with the fibula was inserted. It's an unstable fixation, weight into non-union. Here you can see the biology is still active. This patient needs only stability. You give stability, the fracture will heal. And we are planning for the lengthening of this patient. See another patient, osteomyelitis, treated conservatively. There is no evidence of involucrum formation in spite of 9 months of immobilization. We debrided it and sent this patient to the plastic surgeon. Our plastic surgeon used to have transferred the vascularized fibula. So we sent the patient to the plastic surgeon. But the plastic surgeon failed once, failed twice. Again, he used both the fibulas along with the iliac crest, but he failed. And patient comes to us in this sort of situation. Again, this patient fails to unite because of the instability. Here you can see both the crest has been used, both the fibula has been used. We use only the giving the stability, fracture unites. And we are lengthening this patient. The lengthening process is on. See another patient, bilateral compound fracture shaft of the femur with severe infection and head injury. Fixator is come out because of the infection. Scarring of the thigh where split skin graft was done. So this patient needs debridement and stable fixation. We apply the real fixator on one side and dissect and achieve the length. And on the other side, debride it thoroughly and apply the ring fixator. Here, as time passes, we dissect it, fracture united, and we are now planning for the correction of the deformity. But the patient is not willing for the correction of the deformity. This another side was treated by using the fixator by debridement, giving stability. The fracture unites well. It's a very common phenomena we often get in children following osteomyelitis, segmental loss of the bones. Here you can see the loss of the radius along with shortening of the forearm, deformity of forearm and deformity of the wrist. Here simply we use the fixator to stretch out the scar tissue and the fibrous tissue. Once you have stretched them out, then we simply translocate the fibula ulna in the defect and using the intramedullary wire. You can see the good functions and nice healing. Say under patient RTA, amputation on one side, circumferential loss of the soft tissue from the dorsal and volar aspect of the lower third of the forearm, along with segment of loss of the median nerve and the ulnar nerve. We did abdominal flap and used the sural cable graft, fill up the defect in the median nerve, and use the fibula as a spacer to gain some length in the forearm and plated it. The patient has protective sensation in the hand and using this as a supportive hand. But despite the advance in the prosthetics, there is a huge functional gap between normal hand and the prosthetic hand. Say another patient post-osteomyelitis, loss of the ulna. We can see the small fragment, proximal fragment of the ulna, which is fused with the humerus. and the radial head is dislocated out. Deformity of the forearm and deformity of the wrist. We can see the good function of this patient and multiple scar on the elbow and the forearm. So we are not going to give him much any function and additional benefit. So we are not touch this patient. So a mobile painless upper extremity is more desirable than a painful stiff upper extremity. Treat the patient, note the X-ray. The 6-year-old boy, compound fracture ulna, treated by Debrima and the K-wire fixation. Failed to control the infection. We debride it again and take out the wire and the distal part of the ulna. But when we see the whole of the ulna was sequestrated out. So subsequently we take out whole of the ulna and use the radial head as a graft and convert it to a single bone. It's a good functional hand. Limitation of the pronation and supination. A side swoop injury came to us after 3 weeks with severe infection. So we debrided it thoroughly, take out the every dead tissue and treat it as a defect non-union. Treat it as a defect non-union and fuse the elbow in functional position. Infected loose plate, the better to debride them day one and give them stability, they will unite. They will unite, infection will control. Infected plate, here you can see the biology is still active. So this patient only needs, the infection was controlled by removing the implant and dead tissue. Still the biology is active. So this patient needs only stability. We give him a stable fixation and the fracture united nicely. A simple fracture, closed fracture, plated, infection will control by taking out of the debrima and the plate. Biology is active. This patient needs only stability. We give him fixator, fracture unites. See, it's a very, very common problem. We often have the post-osteomyelitis defect, in particular in the children. Here again, we apply the fixator, distract the scar tissue, get the length, and once the deformity corrected, use the tricortical graft to fill up the defect, and the defect is nicely healed by using the tricortical graft. Closed fracture forearm infection. We did debrima, control infection and primary docking and stability. Fracture united nicely. The limitation of the pronation supination, otherwise the hand functions are okay. See, closed fracture treated by intramedullary implant, and patient went to doctor for removal of the implant. He subsequently tried to take out the implant from the radius, but subsequently patient developed severe infection, debrima, and the gap. We treat this patient similarly and use a tricortical graft after debrima. And these are the function of this patient. Post-osteomyelitis, loss of the ulnar, you can see the radial head is dislocated out. So we apply the fixator across the elbow, bring the radial head down and convert it to a single bone forearm and use the radial head as a bone graft. These are the functional result of this patient. So to conclude, the osteomyelitis is very common. We have to treat them aggressively to prevent long morbidity, complications like shortening, deformities. So treat them aggressively. Correct the angular deformities as early as possible. Defect less than 2 cm primary docking for the forearm. Defect 2 to 4 cm use tricortical bone graft. Irreparable defects convert to single bone forearm. Irreparable defects in the tibia can be treated by fibular translocation. One bone forearm is a reliable and simple salvage procedure, provides good function. The choice of techniques is decided by the available bone. Intramedullary fixation is better than plate. Intact distal radius and proximal ulna, we can give good functional upper extremity. In absence of the functional radiocarpal joint, mid-carpal movements of 10 to 15 degrees allows good hand functions. Thank you for your patience here.
Congratulations, Dr. Meena. Very nice presentation, excellent cases, beautiful.
Thank you.
And all different types of this thing. I think you could have classified it based on the local area, I mean, the anatomical location or the problems.
The problem is it's very difficult to cover all these things in the osteomyelitis. Osteomyelitis is the bread and butter of the orthopedic surgery. You have lot of the cases pertaining to this deformity and all foot and everything.
Good eye opener.
Thank you.
Shamshul.
Sir, yes, sir.
Just check for the questions in the chat box or YouTube, wherever, or if
Okay,
anybody
sir.
has any question.
Sure, sir.
And comments from Mangal sir and other panelists.
Sure, sir.
Before we shift to the next speaker.
Right, sir. I think there's no question in the chat box.
No questions in YouTube as well, sir, for now.
Mangal, sir.
So excellent cases, sir. All sorts of cases with really challenging cases are also there. So just one question. In some of your cases, yes, a single bone is quite good, but reconstruction of the radius using the fibula, while don't you think it's better in some cases? Yes, on some of your cases.
Particularly the infections, I tried many times. I failed. Many times I failed. Then thereafter, I started using this either translocating the fibula, ulna, or the radius. I failed many times. And in children's, particularly many times, your carpal bone slips towards the ulnar side. So they need some sort of osteotomy to balance the carpal bones. Or many times I need to do radial epiphysiodesis to prevent the slippage of the carpal bones. But I have done these 2 or 3 cases. Otherwise, they behave nicely.
The results are excellent, and you have done the very good thing. Just with in children particularly, I had few cases where I put the fibula and both the bone were reconstructed, and that's a good thing. I'll show in some data. Okay, nice paper. Excellent eye openers. Okay, thank you.
Any more questions? Mangal sir's there. Any comments, sir?
No comments.
So, do we have any more questions? Kamsha, shall we?
Yes, sir. So we can move on to the case presentations. First in the list is Manish sir. So Manish sir, you can share your screen.
Good evening, sir, respected senior and dear colleagues.
Congratulations, excellent talk. You could have concentrated
Quiet.
on one area.
Vasu,
Yeah.
your mic is on.
Sorry, there is a problem.
Okay.
Sharing
Shamshul sir, in the meantime, then can you present your talk? Yes, sir.
Okay, okay. I'm sharing. Yes, sir, just sharing. Good evening, everyone. My case is not a primary osteomyelitis, but it is of the iatrogenic osteomyelitis. A 34-year-old male with the injury of leg with severely comminuted fracture of proximal tibia extended to the diaphysis with the severe soft tissue injury, but it was managed somewhere else. And according to the patient, it was a grade 1 injury. Only puncture wound was there. Primarily, it was managed with the external fixator, and surgeon waited for 15 days, and then internal fixation was done. This was the fixation that the surgeon achieved. This was the post-op X-ray, but somehow post-operatively it got infected and the wound complication has occurred. The skin become necrosed and some blackening over the wound is there. And this is the complication that complicated fracture. Now again, she was operated by some other surgeon, and all the implant was removed, and surgeon put intramedullary tense nailing and a K-wire to fix the intra-articular fracture. But still there was the infection, and then this was removed subsequently, and this was the X-ray. Then patient come to me, and there is the non-union, and there is the infection sequestrated bone extruding outside from the skin, and then and there is a depression at the joint. The joint surface is not congruent. Then I manage with the only that the external fixator, that is the ILIZAROV external fixator. I plan to remove the dead bone, and external ILIZAROV external fixator was applied. This much amount of the bone was excised, and near about 8 centimeter gap was created, and the ring was 3-ring fixator was applied, and the foot frame is also applied. And some shortening was also done intraoperatively, and corticotomy done distally. After that, transportation was started after latent period. This was the X-ray of after 6 weeks and subsequent 8 weeks, in which the middle fragment reached up to the proximal metaphyseal portion. And this was the X-ray of after 3 months, and the regeneration was there at the distal corticotomy site. This was the subsequent X-ray, and this is after the 7 month, and the post proximal fracture has united now. I waited more up to the 9 month, and I removed this frame at the 9 month, and I applied for surety. I applied PTV cast and waited 1 more month on the cast, and removed the cast. This was the last follow-up in which patient can be able to walk without support, but there is the pain and in the knee and ankle, and he's constantly saying that there's a pain in the knee and the medial joint line pain. And this was the X-ray. The total frame duration was 9 months, and the range of motion was pretty enough. In knee, it was 0 to 90 degree. In ankle, there is a restricted dorsiflexion. Movement is 0 to 30 degree. And external fixator index is about 1.1. And learning point from this my case is in severely comminuted proximal tibia fracture, disaster can happen even after the staged fixation with internal fixation. So the minimal soft tissue handling should be done in such type of the cases. ILIZAROV is the only solution in these infected, non-united, complicated cases. Thank you very much.
So Manish, why do you think he has got pain in the knee now?
Yes, sir.
Why do you think he has pain in the knee?
Because of the arthritis, sir.
I can see that this X-ray shows me a nice clear joint line.
Yes, sir. The lateral joint is spaced. Lateral plateau is depressed, and there might be have some depression on medial side also.
I am actually trying to make the opposite point that you are making. That even if the X-ray looks terrible, many a times patients have good range of motion, less trouble. Now,
Yes,
for
yes,
example, if he's limping, do you have any full-length X-ray or a longer X-ray?
No, sir, no, sir.
Okay. So what,
Yes.
even in what you can see, what can you tell me about the MPTA there?
It is reduced.
Much reduced.
Yes,
So
sir.
this
Yes,
guy is likely to have
virus
PDL overloading, right?
Yes, sir. Yes, sir. Yes.
So
Definitely.
if this thing is in so much of virus, his lateral condyle is very unlikely to be loading, right? What is his range of motion in the knee?
It is 0 to 90 degree.
Right. So that's that for if you see that X-ray with the, just go to the X-ray with the tens nail.
Yes. Yes, sir.
Yeah.
This was
Okay.
the
Right. So this looks completely sort of horrible. If you ask someone to predict what's going to happen to this knee, they would say that the knee is gone, right?
Yes, sir.
But luckily that thing has recovered and he didn't have intra-articular infection despite all of these issues. Now, so I would suggest now, you should get his full-length X-ray.
Full-length X-ray, yes, sir.
And so when we do ILIZAROV, in the beginning, we are very happy that we are able to get union in very difficult situations. But now, for the next case that you do, once you are getting to union, you should also be assessing the alignment, etc. Is the alignment good? Because with the ILIZAROV on, it is a relatively simple thing to correct that alignment, right?
Okay.
So this is how we kind of go up the learning curve in terms of first तो ये जुड़ गया वही बड़ी बात हो गई. But now once you know that yes, I can get this to heal, then you have to see, okay, can I get this to heal with good alignment or better alignment? That is number one. Number two is just see his video of him walking after with the, yeah, okay. What is happening over here? Why is he jumping?
I removed the plaster just immediately.
Correct.
Just
so
before
one could be the pain.
Yes, sir.
Second, equally incriminated is the lack of hip abductor and extensor power. And the way to test that is if you get the patient to walk with a cane in the opposite side,
okay,
and their limp, etc., goes away, it would kind of implicate the weak hip abductors and extensors. And this can remain weak for months, 4, 6, 8 months after everything has healed. and patients will still be sort of lurching a little. So this is more than a limp. This is more like a Trendelenburg lurch. Though this patient does have a little bit of a painful limp also, but that is the other reason why patients may limp. So we have to work on teaching them the exercises in terms of hip abductors and hip extensors, so that they can do it themselves. It takes, you know, a few days for the muscle strength to go down, and it takes a few months for it to recover. And that is why, along with everything that we do in terms of the ILIZAROV, we have to work on their rehab also. So good case to show how you can get this. Any other comments? Please go on.
Sir, I have a question, sir. In this procedure, can we manage this intra-articular deformity also?
Yes. It is not so much the intra-articular deformity right now which is causing him the pain, but it is the varus overall of the proximal tibia. But yes, you can, in the early period, when go back to the first X-ray.
So this was it.
No, not your first X-ray, the first post-trauma.
Okay.
Yeah. This could have been very well managed with a ILIZAROV. This patient went into internal fixation only because the original surgeon was not comfortable with the ILIZAROV. So
yes,
if he had been comfortable with the ILIZAROV, all this comminution would have thrown so much callus. So you can do a kind of hybrid fixation over here, where you fix the proximal intra-articular portion with subcortical screws or like raft screws. You can even do that with wires, and then the instead of using the plate, you use the this thing. You use the fixator as the bridging construct.
Okay, sir. Yes, sir.
So this is a powerful example of why trauma surgeons should be comfortable with ILIZAROV.
Yes.
Great. So our time is up. I think we go to the next case now.
Yes. Thank you. Thank you very much, sir.
A couple of hands up actually, sir, by Vail sir and Pranav sir.
Okay.
So I wanted to ask, in this situation, is there an option to actually add a fixator, rather a ring in the distal femur part as well?
You
Will
can.
that help in preventing the secondary osteoarthritis?
You can add, but I don't think it is required. If you can get a good fixation on that proximal fragment, then you don't need a femoral frame. I almost never use a femoral frame. I can get good fixation. But if you are worried and you put on a femoral frame, nobody is going to blame you for it. But even if you do put on a femoral frame, it is only about 4 weeks or so to kind of, hold it apart. And then you can take it out and start mobilizing.
Yes.
Great.
Thank you, sir.
Manish, can you elaborate about your angle? You are not on the angle, I mean the foot frame.
Pardon, sir? Hello?
How the foot was stabilized?
Distal frame, distal ring was also applied.
You are not on the image.
Yeah.
Vail, you can ask the question meanwhile while he brings up his screen.
Yeah. This was the ring.
Manish, share your screen. Share your screen.
Yes, sir.
Sir, I also wanted to ask whether only the one ring in the proximal fragment would be enough. If so, what do you told that you will be able to get an stable fixation with the one ring itself? How many wires should we have? The three wires?
About 4 wires.
Okay, sir.
4 wires will give you enough fixation, because ultimately you are bridging.
Okay, sir. Thank you, sir.
Yeah, how is that ring happening? Holding the foot?
No, it is in a heel. The 2 wire was put in.
That's an oblong construct.
Oblong, yes, oblong construct. Yes.
2 half rings connected by plates.
Yes, sir. Yes.
But as you can see, even in this picture, Manish,
yes,
he doesn't have dorsiflexion.
Yes, sir.
So always either you keep a longer oblong, or you keep a separate heel ring and a forefoot ring, so that the ankle movement is
Okay. So
less
then
restricted.
we can also put a wire on the forefoot also.
Yeah, one wire. You normally we put in 2 crossed K wires, where one is going from 1 to 3 maybe, and the other from the lateral side 4 to 4, 5 and 4, and there is a half ring on the forefoot.
Okay, sir. Thank you, sir.
Sir, can the in the post-op X-ray we have seen a little translation of tibia? Can that be the reason of pain, sir? Maybe any PCL deficiency or anything like that, sir? In post-op X-ray, lateral, any lateral.
Where
In that left one, isn't it a posterior translation?
not really.
Okay, sir.
Meaning, if you have 3 and 4 possible causes, I would choose the more likely cause.
Sir. Even in pre-op, we have an anterior intraarticular avulsion, I think, sir.
Yes, but that is now, it's not that visible on this one.
Yes, sir. Yes.
On this one, it's not visible.
Okay, sir.
I'll try meanwhile to find if I can see some cases which we have done with only this thing. I'll try and show it at the end. Okay, next case.
Please share.
Shamshul sir has a case to present actually.
Who?
Please share the screen.
Very.
Akansha is visible?
Yes, sir, but I don't know why it is zoomed in. Maybe if you can just zoom out once. Sir, visible now.
Carry on,
Is it
carry
okay?
on.
Yes,
Okay,
sir.
okay, carry on.
Is it okay?
Yeah, sir,
Yeah.
it is again zooming in when you are
Okay.
trying to share. Probably.
Share the whole
Yeah.
window.
Actually, share the whole screen. Share the whole
It's
screen.
there right now, sir.
So this is Akansha okay, or shall I
Sir,
share
this is
again?
good, sir.
Fine,
This is
go
very
on.
good, sir.
Thank you, sir. So these are the different variants in osteomyelitis cases that we face in daily practice. Like these are the cases we have to handle. We have to handle, apply ILIZAROV when not to. So I'll just be having a very short slides on different variants and just 3 to 4 cases, how to apply, when to apply, what modality to apply in these cases. So it can be a femur or a forearm or a humerus, or tibia infected, can do bone transport or just compression. So we have to first check for infection, instability, and deformity. We have to treat the biology first, mechanics second. And with ILIZAROV, we follow in all the cases, the law of tension and stress, stable fixation is very, very important. We don't have to just do bone transport. And preservation of bone supply is very important. If the bone is viable or not, the bone is viable, you just have to fix it, or otherwise you have to do transport. And early mobilization is important in all the cases so that we just get more angiogenesis in these cases. So the 3D principle is divide, stabilize, and mobilize. And the cascade goes like if there is a bone gap present, we have to do bone transport. If no, we have to just assess and fix. There is pus present, we have to do external fixation only. If there is no, we can do hybrid fixation. If there is poor biology, we can do according technique. Or no, we have to do standard protocols. And if finally, if there is deformity, we can do correction with ILIZAROV support or simply correction only. So let's do a short comparison of 3 to 4 cases here. This is a post-plating osteomyelitis of radius annulus that was removed. And here you can see that the mid part is completely sequestrated. Looks like question, but we have to decide. Either we do just remove the sequestrated part, the segment, and do bone transport, or we just have to see if the bone is viable, or we can salvage the part and just do fixation and can heal. So it's a very difficult decision. You can just decide in the OT. You can do CT angiograms and everything, but the main decision is in OT. So instead of doing the bone transport, I just try to evaluate the findings in the OT and do debridement. And I just found the bone was very viable. So I just fixed with the ILIZAROV 4 rings, the 4 marks, so that we can have a 90-degree fixations. And 4x2 ring was applied. And I applied a guide bar. Although guide bar is not mandatory, not indicated in these cases, because this case was very long back. So just do fixation, stabilize the fracture, and mobilize the limb so that we can have good results. So again, guide bar is not important. You shouldn't use internal wires. So here you can see just stabilizing, do a gradual range of motion, and you can get a finally very good fixation. Even though it looked like a dead sequestrated bone, we can still have regenerate, it heals well without any bone graft, without any bone transport. And you can see a very good range of motion and viable bone also. Similar case of humerus non-union with control infections, post-trauma nailing, infected or glass was done.
Shamshul,
yes, sir.
Just go back for one.
Yes, sir.
So, no, for that function.
Okay, right, wait, sir. Yes, sir. Yes, sir.
Yeah. So, he's got flexion extension of the elbow.
Right, sir.
Okay. We don't see wrist movement. We don't see pronosupination. What was that?
Sir, it was good, sir, because the flexion was till wrist only.
My suggestion would be whenever we take pictures,
right, sir.
In the forearm, we should have elbows stuck to the side and then pronation and supination. Because even if suppose like the second picture you see with the arms extended,
right, sir.
If we do pictures of pronosupination in that position, that rotation can happen at the shoulder, right? So this is for the younger guys, so that when we show, we can actually show the good function, right? He has good flexion extension, of course, and this is much better than having an infected non-union. But only then we will be able to recognize. Great, thank you. Please go on.
The thing is, if we are treating the forearm particularly, infected non-unions, commonly there is restriction of the pronation and supination.
Right, sir. So we have usually seen when we fix, then only we see this rigidity. Now going on the similar case of humerus, post nailing, it was gross osteomyelitis. We usually have to remove the nail. Thorough debridement was done. Now again we have to decide whether we should reject the segment and do bone transport, or just see the bone is viable to supply ILIZAROV, and we can gain a very viable bone. Again, with the guidelines was there. So we have to decide, decision is very important. If the bone is viable, we can save the time of the patient. And guide was not important in this case. These are similar cases. And the range of motion is very good. All this, again, in this cases, patient can drive a bike. So active range of motion, active rehab in these cases are very, very important so that we get a very good blood circulation. And then only we get a very good regenerate or union. So in these cases, fixation and rehab is very, very important, and compression is very good. Compression after debridement is very important. If not, we can give according also. So again, the gross trauma crossover injury. You can see there was gross injury. So just fix exercise and test was applied temporarily.
Shamshul, just a moment. Just 1 minute. In the shoulder, the protruding out where that most, though in your case, that shows the good range, functional range, but that wire is very much prone to injure the rotator cuff.
Right, agree, sir.
Okay, so if at all, you could give it from the away from the joint line.
Right, sir.
If at all, okay.
Yeah, we can apply from side, sir. It's very important. Similar, this is a runover case of gross RTA, and X-ray was applied and TENS was applied. Because of the TENS, there was active infection. It was not uniting this with the somebody applied LRS and debridement was not done. TENS was not removed, so the infection still persists. So for the removal infection, we have to do a thought debridement, and no internal infection has to be there. So we converted this into with ILIZAROV and did according to this case. So removal of all the implant, very good debridement of the canal, and applying ILIZAROV, and accordion 3 seconds done. So accordion has very important in this quiz, so that we got a very good union. So we have to decide when we have to go for accordion or not. So this is a very good example of accordion principle with ILIZAROV. So LRS, if you are doing even LRS, if you're doing LRS, there shouldn't be any TENS, and there should be more pins in these cases. This LRS principle is failing here, because we just have 2 clamps. We should have 4 clamps at least, and if not, we can convert them to ILIZAROV. This is again a case of pathological fracture of osteomyelitis, but there was no active infection. So it was just debrided, and ILIZAROV ring was applied, patient was mobilized. So in this case, no debridement, just fixation, and the wound heals very well. So we have to decide whether the infection is active or not. So we have to decide either we should go for debridement or not. So principle varies in different cases, as per the cases, as per the CT, as per the X-ray, as per the cultures. And if there is a regular case of tibia with bone loss, we can just do a bone transport in these cases. It can be simple bone transport. It can be lot bone transport with osteomyelitis. So if there's a bone gap, we can do a regular bone transport in these cases. These are the regular cases with gross osteomyelitis. And then another interesting case. So this is a case of infected nail with gross osteomyelitis in the proximal tibia. Nail was removed and the bone was exposed. So we have applied ILIZAROV, and compression was done, accordion was done, and the part of the bone tissue was exposed. We just apply VAC in this case. So here also we have to decide whether we have to do bone transport, or we can just sustain with the compression and the VAC. So VAC works in a few cases. You can just apply VAC and get a very good soft tissue result, and VAC followed by small skin graft can be done in these cases. So principle varies from different cases. Bone transport is a very good, very good. We have to decide either we have to do the transport or not. If we have a post-traumatic deformity with the plating, we can simply go for deformity correction with the hexapod. And since the patient was not very comfortable with this,
देखने तो दे
सर
तेरा मतलब तू 30 मिनट का टॉक जो है वो 10 मिनट में कर रहा है, आराम से केस कम होगा तो चलेगा.
This was a case of post-traumatic post-plating deformity, osteomyelitis in this case, and finally plate was removed somewhere, and patient came to me like this with a deformity and shortening of the left femur. I did a scanogram and calculated the deformity in this case. The whole deformity was calculated, and then we planned a hexapod in this case. Hexapod was done, and deformity was corrected, and then after patient to leave as such for next few months. But the patient was not very comfortable in the hexapod. So we converted it into LRS, and patient was mobilized and finally was removed in this case. So the master decision table, the scenario, if there is active bone gap, the pass is there, we can have external fixator only. If there is control infection, no gap, we can, no pass. We can have hybrid fixation, there is no gap, poor biology, we can do accordion. If you have bone defect, large gap is just, we can do bone transport, deformity, plus LLD, you can have hexapod or ILIZAROV. So the main complications we have to manage is spin tract infection, joint stiffness, locking start, degenerate, acceleration, neurovascular injury. So infection treatment, biology drives the healing technique, depends on pathology. ILIZAROV is not a salvage. accordion, transport, hybrid or hex support, selection depends on infection, biology, and deformity, not habit. We don't choose the technique. We have to choose the right biology for the pathology. Thank you, sir.
Good. So my only sort of question is,
Right, sir.
You said don't use internal fixation, but in every case of yours, there was internal fixation.
Exactly, sir. So that's why I was saying that in my previous cases, it was long back. I used to use guide wire. Now I'm not using guide wires in any of my cases, sir.
What changed?
Yes.
No. Why you stopped using the guide wire?
Because in
you just now showed us good cases. So why you were using the guide wire?
This was actually the complete collection of the cases, sir.
My question is, why you stopped using the guide wire?
Sir,
when you were using the guide wire, your results were good. So why
yes,
change something that is working?
Sir, in a few cases, when there is infection, guide wire causes persistent infection. So we have to remove the guide wire. So what to give chance for an infection? So we have to remove the guide wire. But there is no infection, you can't use guide wire.
So if what does the guide wire give? That's what I'm asking.
Alignment, sir. Alignment, sir.
I'm saying that Shamshul developed more confidence over the years. He realized that, oh, I don't need the guide wire. Actually, my fixation is stable enough, and that's why he stopped the guide wire. Would I be wrong in saying that?
I think that's true.
Correct, sir.
With experience, that becomes the early stages. Usually we do it.
More than experience, I think it is. Yeah, with experience, your confidence improves.
Right.
Oh yeah, okay. I know I can get this stable. I don't need the guide wire. I don't need the guide wire. So now then you don't use the guide wire. Good collection of cases. Yes. Who's any hands up?
Yeah, Shamshul sir, the case you show, the last case you have shown in the deformity case, you tried it with hexapod first and then you converted to LRS. So
Right.
was it difficult? Like how did you maintain the reduction while you were converting to LRS? Because it
Yeah.
shows that you convert to LRS quite early while there was no callus and all.
While removal, it was very sticky. There's no movement. You just loosen the clamps and there is no movement.
Okay.
Shamsul, do you think that LRS is much stronger than ILIZAROV there?
Not actually, sir. ILIZAROV is much more stronger. It is circular fixator. It is circumferential.
Patient was uncomfortable with the ILIZAROV. That's why he changed it.
Patient was very adamant that if just remove this. And it was not very callous, was not very good, sir.
Was it painful for him?
It was uncomfortable. It was not painful, sir. It was just uncomfortable for him, sir. Not at all painful.
What do you mean? Was it painful for him? Shamshul has put on the frame.
Sir, it was not painful, sir.
How
it was
is it
uncomfortable, sir.
Okay, there's one question from Udit Kumar Buswal. What is your regimen for doing accordion maneuver? So we can ask each of the delegates, and our webinar will go on for around
3 days.
3 days, yeah. Okay, we'll listen only to what Shamshul has to say.
Yeah. So in accordion, I usually do 2 or 3 cycles of around 7 days each of compression, then distraction, then hold for 7 days again, then again cycles of compression, distraction, and hold.
But you don't do a hold between compression and distraction. Compression, hold, distraction, hold, compression, hold. ऐसा नहीं करता तू?
ऐसा नहीं करता सर.
अच्छा, ठीक है. Fine. I think Udit got his answer. Now, any other questions? Yeah. Next. Who's the next person? Pranav?
The next case was by Arvind sir, but he just called that he had to rush for some operative procedure. So I think he's not there right now. So I would request Prashant to please come and present his case. So I think Prashant, you can just Start your screen.
Yes, sir. Is it visible, sir?
Yes,
Yes,
it
sir.
is.
Yes. So, my case is of a young child, around 7 years of age. So he had a history of osteomyelitis around an year back, for which multiple surgeries were done in form of curettage, saucerization, and eventually he landed up with a fracture. And this is the time when he actually came to me.
Yeah, ऐसा
So the
क्यों दिख
patient
रहा
was,
है? छोटा दिख रहा है तेरा स्क्रीन.
sir,
फोन से कर रहा
mostly
है
I'm
क्या?
using an iPad, so
Okay, okay.
so the patient was
Try
taken
holding
for surgery.
the iPad in portrait mode. घुमा
Okay,
के.
sir.
Landscape.
Yeah. Yeah, now it's good.
So the patient was taken for. So is it better now?
Yeah.
Okay. So the patient was then taken for surgery, and I have opened from the same incision. Debridement was done. All the dead tissues were removed. Now the planning was whether to go for a transport or for a fixation, because after removing, I thought that interior, posterior, and major part of the medial cortex was missing. So I planned for a fixation as a primary mode of fixation with ILIZAROV. So ILIZAROV was applied along with fibular osteotomy and application of stimulant beads. I kept the frame in a way that if I need transport in future, then we can plan that. This is 4 months post-op. These are the clinical range of movements. Everything healed at this stage. And reloading in this patient was done around 6 months. And after which reloading phase 2, and then the fixator was removed. After removal, almost everything healed. The range of movement was all within normal limits. This is the final X-ray, and this is the final outcome. Thank you.
What was done there? We done only fibular osteotomy.
Sir, only ILIZAROV was applied as a primary mode of fixation, along with just keeping the TBI in alignment.
You did any stimulant there?
So stimulant beads were packed in the tibial canal.
Okay.
Few were left at the place where there was a defect, and proximal and distally it was packed.
Then the fibula was cut there?
Fibula osteotomy was done around 5-6 centimeter from the ankle.
Yeah, why? What was the aim of that fibular osteotomy?
So when I was trying to manipulate and I was trying to bring this tibia in alignment with the proximal part, the distal one with the proximal part, it was a bit of difficulty doing that.
Right.
So then I thought of doing a fibular osteotomy.
And why all these things, 3 rings are connected with single rods?
So better would have been that we connect the 2 rings distally with 1 rod and 2 rings proximally with a different rod.
Is a single rod, no? Single rod is for transport.
These are single rods, sir.
Why it was that decision was taken for single rod?
So this particular fixator was applied just as a primary mode of fixation. And if there was a need for a transport, then usually what I do is I cut the rods, the connecting rod with a jumbo cutter. That is how usually I do my transport if I have to convert it. So that way we can change from a fixed frame to a mobile frame.
No, what Vasu is pointing out actually is the opposite, that when you have a fracture situation, usually we use 4 separate rods between the proximal, between ring 1 and 2 and ring 2 and 3. And this,
Yes.
what you have put, is what we use for a classical transport, where the proximal ring and the distal ring is at a fixed distance to each other, and the patient only turns the nuts on the transport ring. That is, am I right, Vasu? That's what you are asking?
Yeah. And no, doing this, working with the full rod is very difficult, no? Putting a full long rod in and out, changing it all will take time.
So usually I make a preformed tibial frame, particularly in tibia. So that way it becomes a little easy for me if there is four single rods.
Have you compressed it?
So
Later
at
on,
the time of operation, yes, I have compressed it.
how you compressed it distally?
Sir, I have not particularly compressed it with the ILIZAROV only, but at the time of operation, because there was an open wound, so I was able to do it manually.
No, post-op later on.
Later on, sir, I have not done any accordion, no compression, nothing. Only the patient was allowed full weight bearing after the operation.
Okay.
Because I thought that it is not needed. If it was needed, then we could have done the compression from the distal most ring.
Right. Any more questions on that?
So there's a question in the chat box by Ravi, sir.
It's not a question actually. It's just a repetition of what Vasu sir said. Because when you apply the single rods, don't you feel, Prashant, it's becomes more difficult to align the fragments, and in those situations, it would be easier. Maybe you may not require the fibular osteotomy as well.
So before putting the frame, I tried actually to bring the proximal fragment and the distal fragment in line, but because it was almost years and years of this surgery, so I was not able to do it. So even if I have thought of going for a single rod, then also I thought it would be difficult for me to align it. And if I have to convert this particular frame to a transport frame also, if like, for example, if I have to cut the tibia, I could have done only the proximal osteotomy of the tibia. Yeah, and they could have transported the tibia only. So I could have converted this frame to a transport frame.
Okay, that can be done in that other way also. It's okay. That's a good outcome, good result.
So for the younger ones among you, what Ravi just demonstrated was the art of making a statement disguised as a question. What he said was that if you have separate rods between the rings, then it's much easier to correct. Suppose this is not perfectly aligned, especially when it's a long-term thing. If it's not perfectly aligned, then with a single rod, it becomes difficult. Whereas if you have separate rods in between the rings, then between two rings, you can use coupled washers or a hexapod or whatever, and alter that a little bit. So that's the reason I think most of us stick to, unless it's a classical transport, we stick to separate rods between the rings. We find it is generally easier.
Yes, sir.
Yes, sir. Thank you, sir.
Who's next?
I think there are no more cases because the last case was by Arvind sir.
I'll try and share my. I don't know whether I've been able to find that. Let me see.
Vasu sir, you're on mute.
Now, what is the role of ILIZAROV in osteomyelitis?
I was going to ask that when the first set of presentations started.
Yeah.
What is the difference between osteomyelitis and infected non-union?
That's what I was confused when I saw the title. So what is ILIZAROV doing for osteomyelitis?
Nothing. So osteomyelitis, I mean, essentially most of the cases that we saw today were infected non-unions. If there is an infected non-union, there will be an osteomyelitis in some place or the other.
Yes.
And when there is infected tissue, then you take it out. That's all. Let me just see if I can share this. I wasn't able to get anything on a fracture, but I have something with a late presentation of a fracture because I don't get much fractures. Now here, Vale, you can see that these fragments are kind of similar to what this guy had shown. Apna Manish.
Yes, sir.
Right. So here the goal was we had to get these fragments kind of aligned because you can see that posterior fragment is dipping forwards. So we do that with under Siam with a blunt Homans to punch up the fragments. So here you can see that the Homans is on the anterior aspect of that posterior fragment trying to push it up. And then once that has happened, we have got fixation of this fragment. So really speaking, the fragment is only if you can see it, the proximal fragment is this. Rest of it is all comminution. In fact, you can see in the you can see in the pre-op, you see how much it is impacted. This portion, which should have been here, has gone all the way in. This fellow should have been somewhere here. And then we use the ILIZAROV to hold it in position. So we've been able to distract it a little. But here there is only like, I think, 3 wires because we were able to get good screws in. And these are all fully threaded, just essentially to hold them into position. With you clamp it with a patellar clamp or a condylar clamp and then just put in a fully threaded screw because I think that is stronger. So that's him at the end with that. And he didn't have a femoral frame. This was only a tibial frame. And he's a little short because we didn't get him out to full length, but function wise he's pretty good. So I think even in this one, if you see for these condylar fractures, it's not always necessary. But so as I said, it is not that anyone can blame you if you don't. Rather, anyone can blame you if you put on a femoral frame. But just like Shamshul was showing that now he finds that the what do you call internal wire is not required. If when you are putting in the wires, no, we are also getting a feel of what is the resistance to this wire. So if my wire is holding bone through and through, and I have 4 wires which are spanning anterior to posterior on the medial as well as the lateral side, then there is very little reason to because above those wires is a completely mobile area. So even if there is some stress, it will happen in terms of knee movement. As long as your wire is put in the proper ILIZAROV way in terms of a single pass, not into empty areas and stuff like that. So I may spend a little time ensuring that my wires are put in properly. But once I have that good feel, then I don't think that a femoral frame is necessary. How often do you use a femoral frame, Vasu?
When there is a ligament injury,
Yes.
that is
In
only
that situation, yes. And when there is a ligament injury and the knee is unstable.
Yeah.
Meaning if there is a ACL tear and the ACL is slightly avulsed, then I don't think you need it. But there is a MCL or LCL along with that, there is some posterior subluxation in that. That's a different case.
Yeah. After putting the tibial frame, I check the stability of the knee.
Yeah.
Okay, sir.
So that is actually a partial subluxation of the knee rather than a proximal tibial fracture.
Yes.
There you can use it.
You can easily put 4 to 5 pin wires in the proximal tibial fragment, and that's more than enough.
Okay, sir. Thank you, sir.
Sir, the 4 wire we apply in the proximal fragment are they all? Can we easily apply 4 wire in the proximal fragment through single ring?
Yes. Single ring means there is 1 wire above the ring, 1 wire below the ring. One is with a little couple of washers or a small drop wire about 7-8 millimeters. So though theoretically, description wise, it is from a single ring. They are not all at the same level. They will be at slightly different levels and slightly different directions. So that is not really a problem.
One thing is that most of the time the wire that goes from the anterior lateral to posterior medial, that got infected most of the time in the posterior side, and that caused huge pain to the patient.
That is when it goes through the pes answeriness, yes.
Yes, sir. How we can avoid that?
Go a little more posterior. In fact, go a little more posterior so that you are through the anterior portion of the gastroc rather than the pes. And in that situation, while the wire, once you feel the give of the wire from the posterior cortex, the assistant should hold it in dorsiflexion and hyperextension of the knee. Both.
Okay.
So the muscle is at maximum stretch. When it is at maximum stretch, then when it's contracting, it doesn't give pain. If you don't hold it in maximum stretch, then it causes trouble.
Thank you, sir.
May
There was one more. I can't find that. I'll show you all that next time. Actually, what I was talking of, no single ring. I'm not able.
How often you do corticotomy to burn the infection?
To burn the infection?
Yeah. Infection burns in the fire of corticotomy.
Fire of regenerate, never.
Regenerate.
I rely on my debridement to set that off.
Yeah.
But yes, I may use a osteotomy just to get it, lengthening better and to get the length as a kind of going ahead with the full rehab, but
not to create the fire.
Not to create the fire, no. I rather extinguish the fire
by knife.
By the knife, yes. And that is.
Sir, any role of proximal tibia ILIZAROV in on-tracking table, sir? Any experience?
Any role of?
Proximal tibia surgery ILIZAROV with the traction table, sir. I feel it is comfortable with the traction table where we get a lot of we get alignment by the ligamented axis.
I feel doing ILIZAROV on standard table and sprinkling Ganga Jal around the tibia around the table makes it much easier. And my success rate is much higher. Samjha, Rama?
Sir.
You understood what I'm saying?
The Ganga Jal, I didn't get the Ganga Jal, sir.
Ganga Jal. You know what is Ganga Jal, no?
Yes, sir.
So I'm saying that on a plain table, if you sprinkle Ganga Jal around that table, it is as easy as using a fracture table.
Okay,
Now,
sir.
disprove that.
Sir, okay, sir.
How will you disprove it? You can't disprove.
Yes, sir.
So that I have a friend in Jaipur, Dr. Khandaka. I learned one statement from him. Once he was doing something and he was applying some particular strength of betadine or something like that. So I said, why you do this? He said, that's my ritual. Everybody has their ritual. This is my ritual. So some of these things are rituals. We are usually, of course, I don't do as much. I don't do as much trauma as probably you do. Number one. Number two, I have assistants, which if you are doing it alone, may be a different issue, right? So if, for example, you are doing it in a setting where you don't have enough assistants, you are constantly doing trauma, then maybe you can. But you see the other side also, where IT also there is an argument. There are people who will say that you should do an intertrochanteric in a lateral position, and the most comminuted, you can do it more easily in a lateral position without fracture table. Right? You heard that argument.
Yes, sir. Yes, sir.
Correct. So it is kind of similar, that I don't think that it is absolutely necessary. But again, as long as that is what works for you, that is fine.
Ram Karthik,
sir,
in a simple fracture that is not very much displaced, comminuted it's okay. If you can get a close reduction, a fracture table helps you. Suppose you have to open it and get a better reduction. How will you manage on a fracture table?
It will be difficult, sir.
Then how do you know which is going to be the final way of management for a particular fracture?
Like before surgery, if we keep traction table, if we feel alignment is good, we can proceed with that, sir.
That's
if we
it.
feel
If
that
you can manage
there is some
everything
fraction of
close,
the
yeah.
Yes, sir.
If you can manage everything close, a fracture table will probably will help you. But you cannot make it as a general rule.
Agree, sir.
Right. I think we are through in terms of time.
Yes.
Yeah,
Yes,
sir. Yeah. Thank you. We missed Arvind's talk.
Jangid,
We'll
yeah.
try and accommodate him some other time. Okay. Thank you, everyone.
Sir,
Bye-bye.
Thank you so much,
Mangal
sir.
sir.
Thank you so much.
Mangal sir.
Thank you.
Yeah.
Thank you.
Mangal sir.
Thank you.
Well,
Sir,
Thank you,
if
sir.
Meena sir is here, can we
Yeah, I can.
you Vasu
I'm
sir,
here.
can we finalize the ASAMI convo issue? Others can leave out, no issue.
okay.
Okay, good night.
Sir, I'm stopping the live recording, sir.
Yeah, please. I think Jayant sir is also here.
Amar is not there.
Amar sir is not here. Jayant sir.
अलग से ही कर दो ना आराम से
Sir.
अभी वापस देन